Good morning, everyone. I'm so happy to meet you again in this new project, the value of advanced critical care ultrasound in management and follow-up of acute respiratory failure. I was asked to see this 61-year-old male patient because of acute respiratory failure. He is a heavy smoker since 40 years, known case of long-standing diabetes on insulin mixed start, 40 units per day. He asked medical advice in hospital, really admitted to the hospital, CBC, D-dimer, routine chemistry, and chest CT was done, and the patient diagnosed as lung chest infection, pneumonia, and received expectorant, bronchodilator, and antibiotic without improvement. This was in the ER in the hospital, and was charged on this medication and prescribed home oxygen to relieve dyspnea. On examination, the patient complained of mild central chest pain since 3 weeks. On examination, heart rate 90 per minute, sinus, blood pressure 100/70, chest barrel-shaped chest with bilateral basal crackle, heart, distant heart sound, abdomen soft lax. Really, in the chemistry and hematology, there is nothing raised non-cardiopulmonary cause. There was no anemia, no renal failure, no metabolic acidosis. So this patient hypoxia and dyspnea is related to the heart or related to the lung. It's cardiac or chest related. We started the advanced critical care ultrasound. The patient didn't do any echo in this small hospital. And we started the advanced critical care ultrasound. We found this type of inferior vena cava, which is dilated, non-collapsing. So in this situation, you need to think about cardiac or obstructive cause of this dyspnea. It could be a cardiac dyspnea or it could be pulmonary embolism, obstructive cause of dyspnea. You will need to go to the heart. This is the long axis parasternal view. You see here, by visual assessment, the heart is not properly contracting. You see no proper thickening in the inferior lateral wall and the anterior septum, and the distance between the anterior mitral valve leaflet and the septum during diastole is too much, is more than 7 millimeter. And you see also there is wall motion abnormality, and here is the mid part of the anterior septum is not contracting or thickening at all compared to the basal part, and there is also hypokinesia of the inferior lateral wall. For chamber view, also the apex is not moving at all, akinetic apex with hypokinesia of the basal and lateral part. With color, there is mitral regurg, moderate mitral regurg, the aorta is clear, aortic valve. To know the cause of this mitral regurg, this is the two-chamber view. You see the inferior wall is not thickened. There is almost akinesia of the inferior wall, severe hypokinesia of the inferior wall, with tethering and no movement of the posterior mitral valve leaflet at all. You see no movement at all here in the posterior leaflet, and this leads to posteriorly directed jet, which is due to ischemic mitral regurg. Really, in this patient, we have wall motion abnormality, generalized hypokinesia, ischemic mitral regurg, and we did EMA mode. EMA mode is not proper in this type of patient because of wall motion abnormality to assess the ejection fraction, but at least we know the end-diastolic diameter here. I'm almost vertical on the wall, and the end-diastolic diameter here is too much, 6.7, denoting chronic process, because maximum end-diastolic diameter in males should be 6.2, but here it's 6.7. That means it's chronic process. This patient has chronic process, which is ischemic heart disease going to ischemic dilated cardiomyopathy. And we did MAPSI. MAPSI is not ideal for this patient because of wall motion abnormality. We did 4-chamber Simpson methods, 4-chamber view. The ejection fraction was very low. And this is ideal really in patients with wall motion abnormality. It's ideal to do Simpson method to assess the ejection fraction. We did right side function. TAPS is good. The diameter is good on right side, and the aortic valve is good. Maximum velocity is low, and the mean gradient is low. Aortic here is no diastolic regurg, aortic regurg. Aortic valve is clear in this patient. So, advanced critical care ultrasound assessment, severe left ventricular failure, ejection fraction below 30, probably chronic or acute on top of chronic because increase in diastolic diameter and volume. It's mainly caused by myocardial disease because of wall motion abnormality, thin wall, dilated left ventricle, suggest ischemic heart disease more than stress myopathy. Because stress myopathy is acute process, you will not expect this too much dilatation of end diastolic diameter, which in our patient is 6.7. Left side valve disease is not the cause, probably normal aortic valve, and the mitral valve is only mild to moderate mitral regurg, will not cause this too much dilatation and wall motion abnormality in our patient, no pericardial disease. So if you see left side heart failure, you need to assess the muscles, valve, and pericardium in our patient. It's mainly muscles and moderate mitral regurg. Okay. This is very important question from the advanced critical care ultrasound point of view. Does the chronic severe left ventricular failure is the cause of acute respiratory failure? Is the cause of this hypoxia? It's very important to do hemodynamics study in a patient with left ventricular failure. From the advanced critical care ultrasound point of view, I need to confirm the degree of right side systemic congestion and the degree of left side pulmonary congestion for sake of follow-up of my patient. In advanced level of critical care ultrasound, you need not only diagnose left side heart failure, but you need to diagnose if there is any increase in left side pressure, left atrial pressure, and does this increase lead to pulmonary edema or congestion, and the same in the right side. Is there any right side increase in pressure, and if increased pressure, does this pressure affecting the systemic congestion, leading to systemic organ congestion? This is very important to follow up your patient. First, right side systemic congestion, venous excess score. From the advanced critical care point of view, you need to not only diagnose inferior vena cava is dilated and non-collapsing, but you need to know the degree of systemic congestion by VExUS score or venous excess score. If the inferior vena cava is dilated and non-collapsing, if it's more than 2.1 and non-collapsing, the patient has right atrial pressure of 15 millimeter mercury according to the American Society of Echocardiography. So our patient has 15 millimeter mercury as regard central venous pressure or right atrial pressure. But does this pressure cause systemic congestion or not? This is the venous excess score. This important article, they talk about this score to assess the degree of systemic congestion. Like left side heart failure, you need to assess the lung for the B-line and congestion to assess the degree of left side increased pressure and left side congestion, and right side congestion you need to assess the degree of systemic congestion. This is because assessing the inferior vena cava per se will not solve all the problem, because inferior vena cava may, for example, be congested, dilated, non-collapses in athletes without any systemic congestion. Okay. What is the venous excess score? Think about venous excess score as to advanced level of assessing systemic venous congestion. Dilated, non-collapsing inferior vena cava will give the first clue. But does this dilated inferior vena cava and increase in right side pressure is reflected to the systemic organ, to the gut, to the liver, to the kidney? Is it reflected or not? Like exactly the left side pressure. You may diagnose left atrial pressure increase, but does this increase causing pulmonary congestion and pulmonary edema? the first step, as in our patient, you will assess the inferior vena cava. If it is less than 2 centimeter, okay, that means you will not apply the score. But if it's more than 2 centimeter, like our patient, you will apply the score. If you have here right side increase in right side atrial increase in pressure and inferior vena cava dilatation and non-collapsing, it will reflect on the hepatic vein, it will reflect on the liver, and it will reflect on the portal vein, which will reflect on the gut, and will reflect on the renal vein, which will reflect on the kidney. So you need to assess the effect of systemic congestion on the liver, on the gut, on the kidney, to be sure that this high right side pressure is doing harm to the patient. Normally, if you put the pulse wave Doppler on the hepatic vein, you will see this type of waves. You will see first big negative wave of systole, denoting contract systole of right side or right ventricle, and small another negative wave of diastole, and positive small wave of atrial kick. If you see the negative systolic wave is less than the systolic wave, that means it is mild abnormality, and in the venous access score, this will be mild abnormality. But if you see only one negative diastolic hepatic flow here, only one negative wave, and 2 positive wave, which is the atrial kick, and systolic wave, that means it's severe abnormality. Okay. This as regard the hepatic congestion or the hepatic vein. What about portal vein? The hepatic vein, if the pressure increases the right side, will be reflected in the inferior vena cava, will reflect in the hepatic vein. But between the hepatic vein and the portal vein is the sinusoid in the liver. This sinusoid really has very good compliance, so can absorb any change in pressure in the right side, and this change will not reflect it on the portal vein, and usually you will see the portal vein flow is almost straight with very mild undulation here, very mild decrease here, less than 30% between the peak flow and the least flow here, or the minimum flow. Okay? What if there is severe congestion and severe increase in right side pressure? It will be reflected on the sinusoid and will decrease the compliance of sinusoid, so the pressure in the right side will reflect on the portal vein, and you will see too much undulation here and too much fluctuation of the pressure of the portal vein. If it is more than 30% fluctuation but less than 50%, it's mild abnormality. If it's more than 50%, it's severe abnormality. Also, the flow in the renal vein will be damped and will lead to continuous nice flow of the renal vein here below the baseline. But if there is too much systemic congestion, this will be reflected on the renal circulation, renal venous circulation. First, in mild abnormality, you will see systolic wave separated from diastolic wave of venous flow, and if too much abnormality, systolic wave will be become upright, like systolic wave here in the hepatic vein, and will be masked by the arterial wave here, and you will see only one diastolic flow. So if you see separated systolic and diastolic flow, it's mild abnormality. If you see one diastolic flow, it's severe abnormality. Okay. If the inferior vena cava is more than 2 centimeter and you have any mild abnormality or no abnormality, it is grade 1 systemic congestion. If the inferior vena cava is more than 2 centimeter and you see one severe abnormality here, systolic wave reversal in hepatic vein, or maximum undulation here and fluctuation of portal venous flow, or only diastolic flow in the renal vein, that means any one of these with inferior vena cava more than 2 centimeter, it's grade 2. If you see inferior vena cava more than 2 centimeter and 2 abnormality, that means it is severe or grade 3 systemic congestion. From the advanced critical care point of view, you need here to assess the degree of systemic congestion to follow up this congestion by treatment to reach for the proper no grade 0 or grade 1 systemic congestion. This VExUS score was applied in a large study in the post-cardiothoracic patient, and there is and revealed a very specificity between the degree of the systemic congestion and the acute renal failure in this type of patient. Back to our patient. Our patient has inferior vena cava dilated more than 2 centimeters, so we need to apply the VExUS score. First, I will put the pulse wave Doppler here in the hepatic vein in the epigastric view here. As you see, the flow is parallel to the vein and will give very nice flow. Normally, this is the hepatic vein going to inferior vena cava, and this is the right atrium, tricuspid valve, and right ventricle. Normally, with right ventricular contraction in systole, the tricuspid annulus will drop towards the apex here, will increase the volume of the right side, so will decrease the pressure in the right atrium, and you will see the high flow here in the hepatic vein away from my probe, negative wave here towards the heart, and you will see very prominent systolic wave, and gradually we reach to the baseline with accumulating blood in the right atrium here and increased pressure, so we'll stop the flow at the end of systole here. But with opening up of the tricuspid valve and the gush of blood from the right atrium to right ventricle will decrease the pressure again in the right atrium, and you will see too much flow again in the hepatic vein because too low pressure here, and you will see this another diastolic wave. Very big systolic flow and small diastolic flow, and this is the atrial kick with atrial contraction at the end of diastole. The blood will reflected back, will go back here in the hepatic vein towards my probe, will give this small wave. But in our patient treatment, for simplicity, you see, if you see any positive two waves here beside each other, that means systolic reversal. So our patient has one severe abnormality here, systolic reversal of in hepatic venous flow. Here is the portal vein. Here is my probe in the anterior axillary line, 7 intercostal space. The portal vein is red because blood is towards my probe, so you will expect flow above the baseline, but you will expect normal flow to be straight, not undulating like this flow, and too much undulation and fluctuation of the flow. The maximum is 19 centimeters per second, and the minimum is 9. That means more than 50% difference. That means there is severe abnormality because of this undulation flow in our patient. We have two severe abnormality. In renal flow in our patient, we don't see this nice flat venous flow, but we see this separated systolic and diastolic flow, systolic and diastolic flow, systolic and diastolic flow, and this is grade 1 abnormality. This is exactly like hepatic vein. This is the systolic flow, but here is smaller than the diastolic flow, and this is the another big due to overfilling of the right side and increased pressure in the right atrium at the end of systole, and this is the diastolic flow, and this is the atrial kick. Okay, but if you see this separated flow, systole, diastole, systole, diastole, that means you are dealing with grade 1 or mild abnormality. So our patient has grade 3 systemic congestion. That means the severe congestion. This is advanced level of assessment of the hemodynamics in the right side. What about left side? Left side, our patient has straightforward ischemic heart disease, wall motion abnormality, and dilated left ventricle, and very poor ejection fraction. That means our patient has cardiac disease, has left side heart disease. To apply the hemodynamics as regards left side pressure measurement and pulmonary congestion, it's very easy. You will apply the recent diastolic functional assessment of the American Society of Echocardiography and the European Association of Cardiovascular Imaging 2016. you need to put the pulsed wave Doppler at the tip of the mitral valve. If you see any patient with left side heart disease, you will put the pulsed wave Doppler here at the tip of mitral valve. If the E, and you will determine the E over A ratio. If the E over A ratio is more than 2, that means your patient has diastolic grade 3 diastolic dysfunction and increased left atrial pressure. Okay, and this patient is congested and need diuretics. But if the E over A ratio is less than or equal 0.8, the E wave is small, and E wave is less than 50 centimeter per second, like this, E wave is less than 50 centimeter per second, and E over A is less than 0.8, that means our patient has here grade 1 diastolic function and normal or low left atrial pressure. And in this patient, you can think about mini bolus if the patient is hypotensive. But if there is this two possibility is not there, and the E over A is between 0.8 to 2, and the E wave is more than 50 centimeter per second in this gray zone. Really, in this situation, according to the guidelines, you need to do 3 parameters, to assess 3 parameters. First, you need to do tissue Doppler and assess the E over the E prime, average one, and if it's more than 14, that means it's pulse point. You need to assess the tricuspid regurg velocity, maximum velocity. If it's more than 2.8 meter per second, in another pulse point. You need to assess left atrial volume index. If it's more than 34 milli per meter square, it's another pulse point. If 2 or 3 of these are positive, that means your patient has grade 2 diastolic dysfunction with increased left atrial pressure. But if 2 or 3 is negative, you need to, that means your patient has grade 1 diastolic dysfunction and normal left atrial pressure, normal or low left atrial pressure. Back to our patient. Really, in our patient, because of tachycardia, I cannot assess E over A prime. And this is common problem, really. You cannot see where is the A or the A because of tachycardia and fusion of the both E and A wave. In this situation, some opinions say you can take the maximum as E, but this is, I didn't read, and some experts use that, but I didn't read in anywhere. And if you have any idea about that, please you can do in the comment. In this situation, if you use the big wave here as E wave, that means you will see here E over E lateral E prime, it is 12.7, but E over septal E prime here is 20. That means the average is more than 14. But in this situation, please, you need to know if there is left atrial pressure is high or not. In this situation, you can go to the left atrial volume index. In our patient, it's 36.6 milli per square meter. It is high, more than 34, and tricuspid regurg velocity is more than 2.8 more than 280 centimeter per second. That means it's 300. That means it is high. So now I have 2 points positive. That means the patient has at least grade 2 diastolic function with increased left atrial pressure. What is from the advanced critical care point of view? You need to look for the end organ of the left side congestion, which is the lung. I went to the lung. Really, I saw a lot of P lines. A lot of P lines with clean pleura. I didn't see any subpleural consolidation here, any black area below in the pleura. I see here too much B lines, and I didn't see any subpleural consolidation. Despite extensive P line all over the lung, pleura is clean without subpleural consolidation, so it's cardiogenic pulmonary edema. Proper diagnosis equal proper treatment. Good diagnosis, good treatment. In our patient, while our patient probably have ischemic cardiomyopathy, ischemic heart disease, we prepare for coronary angio. Patient receive diuretics. We give spirolactone, furosemide, antiplatelet, anticoagulant. No beta blocker in cardiogenic pulmonary edema. Follow-up study. Inferior vena cava decrease a lot. In this situation, you don't need to do VExUS score, venous success score, but I did it for sake of this patient. Follow-up. You see here the renal flow. Very nice flow. It's not interrupted flow. Very nice flow here for systole diastole, because good damping of the venous flow, and also in portal vein, no too much fluctuation. and even the patient improve mitral valve because mitral valve is load dependent, started to decrease a lot, You see even the contraction started to decrease a lot. You see here, this is a moderate mitral regurg, here is minimal mitral regurg really. And you see even the inferior wall start to contract properly compared to this one. Inferior wall starts to contract properly. That means it is hyperinated myocardium. This patient has hyperinated myocardium properly, definitely has hyperinating myocardium, which starts to improve with treatment. And Simpson method ejection fraction increase. It's 27 now for a chamber. And left atrial volume decrease now. It was 66, it's now 55. And we started to see E separated from the A. And E over E prime, it's not high. E over lateral E prime, it's 9 here. That means it is negative point. And left atrial volume index negative point. That means we shift to grade 1 diastolic function with normal left atrial pressure. And this is the lung at the beginning, and this is the lung after good diuresis for this patient. You see B line replaced by A lines all over. Patient has multiple coronary artery disease for cabbage. What are you going to change? We really, after this deluding the patient, we start beta blocker. And the take-home message, advanced critical core ultrasound, it's not only diagnosing left side heart failure, but you should know what about hemodynamics, what about left atrial pressure. If it's high, you will diurese the patient. If it's low, you can give many fluid challenge. And if the right side, if the inferior vena cava is dilated, non-collapsing, it's not the end of story, but you need to assess the degree of systemic congestion, the degree of hepatic congestion, gut congestion by portal vein, and renal congestion by renal vein, and to assess exactly what is the grade of venous excess score, and you will give fluids, and you will re-look to the end organ, you will re-look for the B line in the lung to be sure it's cleared, and you will relook on the systemic congestion and be sure the VExUS score will decrease in grade to at least grade 1 and grade 0. And thank you a lot for your appreciated listening, and see you in another project. Bye-bye.